Good afternoon. Welcome to the Kirby Institute Seminar Series. My name is Greg Dorr. I'd like to begin by acknowledging the traditional custodians of the lands on which we gather today and pay my respects to their elders past and present. Today we're presenting from Bidjigal lands, the Eora Nation. I extend that respect to Aboriginal and Torres Strait Islander peoples joining us today here in the audience and online. Just a bit of housekeeping. Many of you will be familiar with the format of the seminar, but just to refresh, we'll start off with a presentation followed by a Q&A session. If you're joining us online today, you can ask questions by clicking on the Q&A icon at the bottom of the screen. For our audience in the room today, the microphone will be made available for the Q&A. Okay, it's a great pleasure to welcome Michael Kidd to the Kirby Institute. Michael's a professor and director of the Centre for Future Health Systems at UNSW and professor of global primary care, Nuffield Department of Primary Care Health Services in Oxford University. Michael has had many awards and recognitions of his service, including an Order of Australia, and is the foundation director of this new centre. And I think he's one of the few people that have the experience of a really long history of clinical care, government involvement in policy, and also academic sort of leadership in many areas. So he really is incredibly well situated to have fulfilled the role that he did during the COVID pandemic and to present his perspectives on how Australia responded to the COVID pandemic. So it's a great pleasure to welcome Michael to the Kirby. He's been a friend of the Kirby for many years, so it's great to have him here this afternoon. Thanks, Michael.
So good afternoon, everybody. I think it's afternoon. And thank you for the opportunity to come and join with you today. Thank you to those who are joining online as well. As Greg said, I'm really pleased to come, and I've been asked to talk to you about some perspectives that I've gained from working with the Australian government on the COVID-19 pandemic response, and perhaps provide some tips on how to particularly make sure that your research is having a direct impact on policy and practice. Now, it feels like the wrong audience to be teaching this to, because the Kirby Institute has a very long history of being highly influential when it comes to government policy and influencing clinical practice. So thank you for all that you've been doing, but we'll see if we come up with anything else as we go through. I want to acknowledge Raina McIntyre, who's here in the audience, who we worked together on a number of initiatives throughout the pandemic, and also my new colleague at Oxford, Professor Trish Greenhoe, who's here in the room with us as well, here for the World Organisation of Family Doctors Conference, which is taking place in Sydney later in the week. So to start by also acknowledging the traditional owners of the lands where we're all meeting today, the Bidjigal, the Gadigal and the Ngunnawal people with our Canberra campus. And I'm going the wrong way. There we go. So COVID-19 upended most of our lives in ways that none of us could ever have really predicted. And of course, we've lived through it. I am conscious that talking about COVID-19 and the pandemic can be triggering for some people. I know some of you will have lost loved ones and friends during the COVID-19 pandemic. And so I apologise if the talk causes you distress. It is important, though, that we learn the lessons from the pandemic and that we enshrine those lessons in our healthcare systems moving ahead. And I'll talk to you a little bit about that as we go through. One of the privileges that I had during the pandemic was co-chairing the National COVID-19 Health and Research Advisory Committee with Professor Sharon Lewin, who's no stranger to most people in the room, and Raina was part of that committee. We were brought together very early in the pandemic at the request of Minister Greg Hunt, who was the then Minister for Health and Aged Care, in response to just about every health and medical researcher in the country putting up their hand during January and February of 2020 and saying, how can I help with the Australian government response? What can I do to help with how Australia deals with this new pandemic and to help to protect and save the lives of fellow Australian citizens. So we had an extraordinary group of research leaders who came together as part of that committee. We had consumers as part of the committee. We had clinicians from a broad spectrum of groups. We had people representing the perspective of people living in aged care, people with disability, people from cultural and linguistically diverse backgrounds, Aboriginal and Torres Strait Islander people, a number of the priority populations who we were concerned about at the beginning of the pandemic. And we also, in the spirit of bipartisan approaches to a national emergency, which of course was very much part of our responses to HIV/AIDS, Greg Hunt appointed two members of parliament, one from the coalition, Katie Allen, who's a distinguished doctor from Melbourne, and the other from the opposition, Dr. Mike Freelander, who many of you will know, who's a paediatrician and MP in the UNSW catchment areas. So it was terrific having both sides of politics there in the committee as well. We worked with the National Health and Medical Research Council, who provided the Secretariat and who, of course, are very experienced in developing guidelines, in doing reviews, quite rapid reviews of the evidence to help the decision-making by the Chief Medical Officer at that time, Professor Brendan Murphy, and by the Australian Health Protection Principal Committee, the AHPPC. And I just want to show you just a few of the early reports that we released. This one in May of 2020, looking at ethical issues arising from the COVID-19 pandemic. We had a real concern about what would happen in Australia if we reached a point like they had in Northern Italy of having to make decisions about who gets access to treatment, who gets admitted to hospital and who does not. And we actually got the Australian Health Ethics Committee set up to deal with those ethical issues as they came forward and to provide advice to government. We ended up using that process to particularly help us decide about who got access to some of the limited resources that we had, particularly antiviral treatments early in the pandemic. We did a review very early on the mental health impacts of quarantine and self-isolation. We were very worried about the disruption in life, which we saw certainly with the first lockdown in Australia in March and April of 2020, and we anticipated there were going to be other lockdowns, but also on the people returning to Australia who are having to go into quarantine for 2 weeks, which continues to be a bit of a live issue, as we've seen bills going out over the last week or two in this state to people who had hotel accommodation. Immediately after the initial lockdown in Australia, we did a review of where was resurgence likely to happen if we had a second wave of COVID-19 in Australia. And we did this because, I don't know if you remember, but after the whole world went into lockdown in March and April, Singapore had a second outbreak almost immediately, and it occurred in the dormitory suburbs around Changi Airport, where the migrant guest workers were living. And Singapore had sort of focused on protecting their citizens, but had forgotten about the importance of public health and protecting everybody. And we were very worried about where the next outbreak might occur in Australia. We had this review led by Kamalini Lacouche, who some of you will know. She has a lot of experience working with Ebola outbreaks. And the report said that we predict that the next outbreak of COVID-19 will likely occur among people of non-English speaking background, among people who are poor families, among large families, and probably through those outbreaks will affect people working in aged care facilities, hospital cleaners, people working in meatworks, people who are stacking supermarket shelves, and many others. And indeed, as we saw saw with the second wave in Victoria. That's exactly how things rolled out. We also were very concerned about the impact of COVID-19 on Indigenous Australians, and we did a review looking at testing and rapid responses in Indigenous Australia. You may recall right at the start of the pandemic, funding was provided to each Aboriginal and Torres Strait Islander community to determine themselves how to protect the members of their communities and to make decisions themselves about whether they locked down communities, restricted access, and so forth. And we also looked at, could we reduce the length of quarantine? This was an ongoing discussion, this 2 weeks of quarantine period which we had. So that's just an example of some of the reviews. There's 40 reviews. We got permission to publish the reviews as they came out. Sharon and I were very strong with the government, saying that we're doing this research, we need to share what we're learning. We have an ethical imperative to do so with the rest of the world. Other people may find these reviews helpful. We did get some negative publicity during the second wave around the report that we'd already put out predicting where it was going to happen and what was the government response and blah, blah, blah. So the reports disappeared for a while on the website, the NHMRC website, but they're all back up there now and accessible to you. I wasn't in Australia when the pandemic began. I was working in Toronto in Canada, and was due to come back to Australia during the middle of 2020 and to work with Brendan Murphy, and got a call at the beginning of February saying, when are you intending to come back? And I think you need to come back straight away and start work. So that's what I did. I came back to Australia with all my luggage, went straight to Canberra, checked into the Abode Hotel in Woden, and didn't check out again for 6 months. That's where I lived, didn't get to go home for the first 6 months. So I arrived, and the Prime Minister had just released Australia's health sector emergency response plan for COVID-19. And Brendan said, we've just launched the plan. The Minister would like a primary care response to the plan. I said, yeah, that's great. He said, so can you work with a couple of the people in the department on developing that plan? I said, that's great. What have you already got? Nothing. And when does the Minister need it? Lunchtime tomorrow. So that was fine. So we sat down to work out what we were going to do. Now, fortunately, I came from Toronto. And I say fortunately because Toronto, along with Hong Kong, Singapore, Hanoi, Vancouver, was one of the cities which had outbreaks of SARS, with the original SARS virus in 2002, 2003, and had deaths amongst its population, including deaths amongst its healthcare workers. And there'd been a number of inquiries after the original SARS epidemic, which had looked at what needed to change to prevent that from ever happening again. And I'd read through those reports. The shadow of SARS was very long in Toronto, and particularly the deaths of healthcare workers. And what I noticed was in Ontario, the province where Toronto is, every hospital that had been built since SARS had been built to be turned overnight into a fever hospital. It had been built so you could have a wall between regular functions and functions dealing with the infectious agent, with absolutely no transfer across the two. They had robots delivering meals and robots delivering medications to the single bed, single bathroom rooms in these hospitals. The other thing I noticed as a GP, a family doctor, the first day I went to work as a GP in Canada in 2016, I was fit tested for a N95 mask, and given a little card, which I still carry in my wallet, saying which brand of mask is the one that fits my face and has been tested to show that I'm safe. And in January of 2020, we all got recalled to get fit tested again in case we got fatter or thinner or grown a beard or shaved one off since we last had our testing done. And, 2 years into the pandemic, we're still arguing about fit testing in the healthcare workforce in Australia, whereas in Canada, it was just part of what they did. And there are a number of other infection prevention control measures which existed there that didn't exist elsewhere. So I took the knowledge from that experience, having thought about SARS and a lot of the knowledge which we all share about the responses to HIV/AIDS in particular, and we developed our national primary care response based around these 5 principles. The principle that primary care would be very actively involved in protecting the people who are most vulnerable to COVID-19. We already knew from the experience in China and in other countries that this would be the elderly, people with chronic disease, people who are immune compromised, and that there will be a disproportional response to a number of priority populations, which I've mentioned. We recognise that we would need to be able to continue to provide treatment and support services to people with symptoms. So we'd have to have a way, when people had respiratory symptoms in particular, of being able to assess them in a safe way. That we would need to continue regular healthcare services for the whole population. Experience from past epidemics and pandemics is that often it's the people not getting access to regular healthcare that can actually lead to significant morbidity and mortality. And we're seeing some of that, of course, now. That the people working in primary care in the community deserved the same level of protection and support against the virus as people working in hospitals, because we didn't know who was going to be infected and where they were going to turn up. And it may be like in Toronto, where the 3 healthcare worker deaths were a GP, a community nurse, and an emergency nurse during the original SARS pandemic. And the provision of mental health services, both to the community, but also to our healthcare workforce, recognising that often after epidemics and pandemics and other emergencies, there's a very long tail of mental health, ill health and distress, and that also affects the workforce. So we developed our response. We developed recommendations against each of them. Part of it was the movement towards telehealth, recommending that we could have consultations remotely, which at that stage was very restricted in how you could use telehealth under the Medicare benefits schedule. We recommended establishing a network of standalone clinics, or converting some general practices to be respiratory clinics. We looked at continuity of care. We didn't want to have a lot of our healthcare services become bankrupt because of loss of income during the pandemic. So there were measures put in place, incentives to keep our services open. Protection of PPE was a real challenge because, as you'll recall, we had a global shortage of PPE very early on. Who knew that many of the paper surgical masks were made in the Wuhan province of China, and it was a real cause of concern amongst many healthcare workers, aged care workers, and hospitals, and their mental health services as well. So we presented that to the Minister the next day, and Brendan came back the next morning and said, "Oh, the Minister really loves the plan and all the things that you want to do. He needs it costed." When would he like that? Lunchtime tomorrow. Okay. So sat down with Simon Cottrell, who some of you will know from the Department of Health, and we started doing the costing. We asked all the different areas in the department to give us their costings by midnight. Nothing came through because everyone was busy working on all sorts of other things, so we had to do it ourselves. So just working out how much to spend. We came up with $1.2 billion of expenses, which really worried me. But if you are totally transforming the model of care, it's expensive. So we came up with that amount, and that went off to the Minister. Brendan came back and said, the Minister's not very happy. He thinks you've undercosted the proposal. He's going to ask the Prime Minister for $2.4 billion. He doubled the amount, and that's what we got. We got $2.4 billion in the original expenditure on the primary care response. One of the other things which I did very quickly was I went to ANU, where at that time I had a joint academic appointment, and said, can we bring some ANU researchers to be in the health department to document what we're doing every day in the pandemic response, so that the next time around when someone says, what do we have? It's not nothing. It's here's the diary of what actually happened day by day by day in the analysis. and to carry out rapid reviews to help inform the policy work that we were doing. And I got these two wonderful researchers, both nurse clinician researchers from ANU, Sally and Jane, who worked with me. And over the course of the pandemic, we did many reviews. We actually published 40 publications over the first 3 years of the pandemic, involving a lot of partners, both in Australia, overseas, people from within the department, and people from the ANU and other universities as well, which was terrific. Again, everybody being willing to give their time. Didn't pay anybody except for Sally and Jane, everyone being willing to give their time to contribute. And I want to share with you some of the papers that we developed and the rapid policy that we did. So what happened? First thing we did was we actually did a rapid review of the evidence from past pandemics to try and work out what were the lessons to share. And we did this quite quickly and then published it. A lot of the publications were published early before they're going through peer review, and then the formal publications came out later. But we thought it was really important to capture those learnings from before so that we could build on them. We documented Australia's national COVID-19 primary care response. We published that in the MJA, describing what we were doing as part of protecting the Australian public. We did a lot of sharing of our primary care response, particularly through the WHO, with people working in many other countries who are interested to know what Australia was doing. We looked at the 5 principles, and we published that early on as well, so that people could look at whether their own national responses were addressing the same sort of areas that we were in Australia. And then reflected afterwards on those 5 principles as we looked over the first year or so of the pandemic to see how it reflected what was happening in other parts of the world. One of the areas which was really challenging, and Raina knows this all too well, was the issue of mask wearing and the advice which was being given, particularly for healthcare workers in primary care. We did a rapid review on this. We gave that advice to the AHPPC and the Chief Medical Officer. We then tried to get it published really quickly. 2 weeks after we'd put it in, it came back saying, no, your data's all out of date, because this is a rapidly moving area. So we did it again and put it back in, and 2 weeks later, no, it's all out of date again. We eventually gave up. But the reason why we were so concerned about this is this little figure down the bottom. By April 15th of 2020, it had been reported that already over 450 healthcare workers around the world had lost their lives to COVID-19. And as the Deputy Chief Medical Officer of Australia, I just felt this very personal responsibility for protecting and doing all we could to protect the lives, the health and well-being of my peers, my colleagues who were working on the front line in caring for people with COVID-19 in our country. And I know that imperative was felt strongly by many people. We looked very early at the importance of consistent advice during a pandemic, and we particularly looked at this from looking at advice that was being provided about PPE in healthcare settings during the early months of the pandemic, because one of the things which we knew from looking at the previous evidence is that if there's different advice coming from different sources, especially from different government sources, the population gets confused, the healthcare workforce gets confused, we all get confused. And I think we were all confused during the pandemic by different advice coming from different levels of government, particularly when we had nationally agreed positions, and then each state and territory, for good reason, would do their own thing and decide what was right for their own folk. This was particularly challenging in primary care because we have primary care, general practice in particular, funded federally, nationally in Australia, but of course rolling out in all the states and territories across the country and bound by public health orders by the different states and territories. So we were getting this confusion by our primary care workforce. We did do a lot of education of our primary care workforce. I did regular webinars for people in primary care at least once a week. The maximum live attendance that we had was 15,000 healthcare workers at lunchtime on a Tuesday, dialing in to find out what was happening with the pandemic and the response. And I think I hit a record of about 200 webinars over the first 3 years, trying to share information with our colleagues. But what we came up with was the importance of having a single source of truth for information for the public and for the professions. And this was health.gov.au, the Australian Government Department of Health website. We also acknowledged that information would change over time. And the media loved it, saying, you said this 2 months ago, now you're saying that. Why is that? Well, the evidence base has changed. Our understanding of this disease has changed. In some cases, new variants have appeared. And so we expected information to change over time. One of the joys I had as the Deputy Chief Medical Officer was fronting up to the Canberra Press Gallery regularly, at least 2 times a week, and delivering a couple of times a week. It was my turn to stand in front of the TV cameras of the nation and deliver the daily figures to people all around the country. One of the times I did this, we usually did around 12 o'clock. We waited for Dan and Gladys to have had their say on the media, and then we went live so that particularly ABC News Channel didn't have to turn one off and put the other one on. But I got a call from the media team in the Department of Health at 2 o'clock in the afternoon saying, "Oh, it's just amazing. Your Facebook recording of your media conference has just hit 2 million views in 2 hours. It's gone viral all around the world." And I thought, wow, 2 million views, viral all around the world. That's just amazing. I must go and have a look at it to see what I said that was so interesting. Well, it wasn't what I said. It was the young person from the department who was filming me at the time who filmed me upside down. And that went around the world viral. Here's the doctor from down under talking about COVID-19. So best laid plans. One of the things I was very pleased about, though, was every time I stood up in front of the nation, I had an Auslan interpreter beside me, working to make sure that that messages were available to people who are deaf and hard of hearing. We also had live captioning of all our events as well. One of the things we were very concerned about right before we went into the initial lockdown was the risks of healthcare and social care workers attending work while they're unwell. So we did a rapid review for government to say this is a real problem. If people are especially casual workers and they don't go to work in the nursing home, in the hospital, wherever, they don't get paid, their children don't get fed. And we presented the evidence to show that this has been a problem in past epidemics, pandemics, and outbreaks. Eventually, of course, we got the job keeper, job seeker arrangements and special arrangements for people, particularly working in aged care. Probably wasn't implemented as quickly as I would have liked to have seen. We also did a lot of work with industry, and I became known as the union whisperer in the Attorney General's department because the unions wanted to talk about what were the risks in people working, particularly in industries where there was risks of people being exposed to people with COVID-19, people working on the borders, people working in our quarantine settings, people working in our healthcare settings, but also areas like the ship workers, the people unloading the ships at the docks, and many others. And we did some work just looking at what the new normal with regard to infection prevention and control in different industries and businesses would be as we moved out of COVID-19 shutdowns. Telehealth, Greg Hunt loved saying that with the implementation of telehealth to the whole population of Australia, we were planning to roll this out over a decade, and we rolled it out in 10 days. So it was a decade worth of reforms that we rolled out in 10 days. It was the most significant change to funding under our Medicare benefits schedule in Australia since the MBS was established back in the Hawke-Keating government. We had to introduce during a week 310 new Medicare item numbers to allow telehealth to take place. There had to be changes to allow initially frail, vulnerable people to stay at home and connect with their healthcare providers, then frail, vulnerable healthcare providers being able to stay at home and connect with their patients. And then by the end of 10 days, as we rapidly move towards the first lockdown, the whole of the population being able to access telehealth. How many of you had a telehealth appointment sometime in the last 3.5 years with your GP? Or yeah, lots of us. Hundreds of millions of consultations rolled out very, very quickly to meet the needs of the population. Unfortunately now, very much a part of our healthcare provision. The majority of those are telephone-based consultations, and there's reasons for that which we looked at. We looked at the challenges of video consultations and what the pandemic had shown us. And particularly, there's great value as a GP in being able to see your patient by video, see the setting that they're in. But there's also real challenges in doing so in a timely way, mucking up the day as people have trouble connecting and the next appointment is due. It's just as demanding trying to do a telehealth series of consults as it is when people are coming to your consulting room. And of course, some of the people who are most vulnerable can't do video calls. They can't get the technology to work for them. Smartphones are not universal in Australia. There are plenty of elderly people who cannot manage smartphone technology, people with cognitive challenges. And it was important to do this research and present it to the Medicare people who were saying we shouldn't have telephone calls, it should all be video. And we're saying, well, if you do that, you will be disadvantaging a large segment of the population. We also looked at all the digital health innovations which came through. Don't know if you're across it, but we had telehealth, we had e-prescriptions, we had point-of-care testing, especially in remote communities, and breaking that gridlock of the pathology industry that the only people who could do quality tests were pathology laboratories rather than these amazing tests that we had, and a lot of information sharing that we haven't seen before so that we could better understand what was happening with the population. We looked at the GP respiratory clinics, the 150 clinics we established across the country. 98% of the population were living within an hour's drive of one of these clinics, so could go to these clinics if they had respiratory symptoms. Very important, it wasn't just COVID, because some respiratory symptoms were other things. And they picked up people who are having heart attacks. They picked up people with pulmonary embolism. They picked up people who had other reasons for their respiratory and other symptoms. But these were great clinics run by wonderful GPs, primary care nurses, and others. A lot of volunteers working to support those clinics as well. We looked at the challenges of continuing routine primary care and presented that evidence as well, how important it was that we could keep the routine primary care going. And I don't know if you could recall, but a lot of the messages from Minister Greg Hunt and from Brendan, Paul Kelly, myself, were about encouraging people to keep going for their chronic disease consultations, to keep doing their preventive care interventions. During lockdown, the number of women getting screened for cervical cancer dropped dramatically. The number of women getting screened with mammography for breast cancer dropped dramatically. The number of people completing their colon cancer fecal blood test in the comfort of their own home rose dramatically because people were at home with nothing to do. And so finally got that kit off the shelf and worked out how to do it and sent that off. And going to post your test was a legitimate reason for leaving the home during periods of lockdown. So it was a bit of an incentive there as well. We had to be careful with the sort of things that we we said, though, I don't know if anyone remembers this, but I caused a run on paracetamol during one of the initial outbreaks of Omicron in Australia, saying that, you need to be prepared, that, we'd open the borders, you're likely to come in contact with COVID-19, you may be unwell, just have your kit at home, have some paracetamol, have some fluids and all the rest, just in case. So if you do get unwell, you don't have to leave home and infect other people. You can stay at home and do telehealth. The paracetamol disappeared off the supermarket shelves. I got into a lot of trouble with the minister over that one. We also looked at the impact on chronic disease management and this big concern that we have around delayed diagnosis and people who didn't get ongoing care for hypertension, for diabetes, screening for cancer and so forth. We also looked at what was happening with sexual and reproductive healthcare. I know this was a concern to people in this room. Telehealth was initially allowed for everybody with the provider of your choice, but then we required that people have seen the healthcare worker that they were seeing within the last year face-to-face, because we didn't want to lose the value of face-to-face consultations. Well, that creates a challenge for sexual and reproductive health in particular. So we managed to do the evidence and then to argue successfully that people seeking sexual and reproductive health care did not have to have that face-to-face consultation in the last year in order to get continuing care. And we're continuing that. This has been a real boon, especially for young people in rural areas around Australia. We looked at mental health. As I mentioned, we're very concerned about a storm of mental health issues, and I think we're seeing a lot of that now. One of the things that worries me most is young people who had their lives disrupted, children who disengage from attending school. Particularly, we've seen this in Victoria. A lot of people, young people, with that sense of hope being shattered out of them as a result of seeing what happens, and of course, watching the news and seeing what's happening right now it adds to that burden on many young people. We rolled out a number of supports for the mental health crisis. Again, it was really helpful to be able to be evidence-based in so much of that work. One of the areas that we were most concerned about was the protection of people in nursing homes, in aged care facilities, long-term care facilities. And we did a rapid review of the international evidence. At the same time, we had a Royal Commission which did a special report on COVID-19 and the impact on nursing homes. And you probably all remember that first outbreak in Dorothy Henderson Lodge here in Sydney, and then Newmarch House, and then the terrible tragedy at the St Basil's Greek Orthodox nursing home in Victoria, and then things just spreading. And of course, we still have elderly people dying from COVID-19 every day in Australia. We still have a lot of the measures in place, though, in many of our aged care facilities right across the country. People still being required to have a negative rapid antigen test, wearing masks while visiting loved ones, and so forth. One of the jobs I was given when the Royal Commission brought down its report was to set up and lead a aged care advisory group to the AHPPC. We didn't have one before. We should have had one before, and we brought together experts from academia, from clinical care, from care delivery, and elderly people themselves to provide advice and to develop the strategies to protect the most vulnerable people when it comes to COVID-19 in our community. The OECD has recently released a report where they looked at pandemic responses across all the OECD countries, all the high-income countries, about 38 high-income countries. What they found uniformly in all the OECD countries, between a third and 40% of all deaths from COVID-19 in the first 2 years occurred in the residents of nursing homes. Aged care facilities. It was the same in Australia as it was in the USA, as it was in other OECD countries. And no OECD countries had a specific focus on protecting elderly people in nursing homes as part of their initial pandemic response when they were rolling out for COVID-19, despite what we were seeing in Wuhan, because we saw elderly people being really badly affected right from the very beginning. And there were some measures which were taken place in the early days in other countries. We're fortunate in Australia with the borders closed, but other countries, elderly people being in hospital with COVID-19, being diagnosed with COVID-19 and being sent to a nursing home for ongoing care or for palliative care and spreading to everyone else in that facility. It was very concerning. We also looked very closely at some of the impact on culturally and linguistically diverse background people. One of the researchers I had working with me is a wonderful South Sudanese refugee who became a doctor at Melbourne University and then got an MPH at Harvard and an MBA at Oxford, and then happened to be back in Australia, and we got him working with the South Sudanese community on what was the experience and what was happening. You probably remember things like the tower block closure in Melbourne, affecting a large number of different refugee families from different communities. And we wanted Garang to do a deep dive into what the experience was from the South Sudanese community, and then see if there were lessons that we could share with others. We set up an advisory group on cold communities with FECA, the Federation of Ethnic Community Councils of Australia, after the second wave in Victoria. I was trying to get it before, but that didn't happen. But the working with the communities, of course, has just been so essential in being able to have good responses. And again, it's lessons you've all been teaching us for decades through the work of the Kirby. And then we wanted to document what happened with vaccine rollouts and the extraordinary contributions of the nation's GPs and also the nation's pharmacies, where the majority of vaccines were rolled out through general practices across the country. Most of the rest of the vaccines through community pharmacies. We had a whole lot of white elephant centres which were set up where people just stayed away from. People preferred to go and see the healthcare providers, pharmacist, GP, nurse that they know and trust to get their vaccines. And we think that that personal relationship was really important in building trust and getting the high rates of vaccine protection that we had across Australia. So what happens next? What happens next is, what do we do with all this information? And one of the things that I'm really concerned about is, and I know many of you are, is to make sure that we don't lose the lessons of this pandemic and that the lessons get enshrined in the changes that we're doing with our healthcare systems. And it's why I jumped at the opportunity to leave the department at the end of June. I mean, I was kind of ready to leave after 3.5 years of being there, but jumped at the opportunity to come to UNSW to set up the new Centre for Future Health Systems, which I'm now in the process of establishing with a branch here at UNSW and a branch also at Oxford in the UK. And one of the 7 themes which we've established for the new centre is to make sure that the lessons of the COVID-19 pandemic are embedded as we plan our healthcare systems for the future, and that we don't lose sight of all the areas where COVID-19 shone a very strong spotlight throughout the pandemic, and make sure that we're prepared in the future. We don't know what the next, well, Raina probably does. I don't know what the next pandemic is going to be, and which part of the population it's going to affect, but it will likely still affect many of the priority populations that were not well looked after early in our responses globally to COVID-19. So I wanted to share that with you as, you know, my journey over the last few years, but also to reinforce for all the researchers, and especially the younger researchers in the room, how valuable it can be working as a researcher, working with government and having that direct impact on healthcare policy. And, you know, a lot of the reviews we did, you know, if we were going to do it normally, we'd be applying for a grant, we might get the grant, it starts a year later, we have a year or two to do it, we get it published, and by which time it's probably largely irrelevant. We were doing these reviews in a week and having them ready for the AHPPC, presenting them and helping to inform the decision-making which was taking place. So being able to be nimble in the work, and, you know, yes, we missed out on a lot of stuff by doing rapid reviews. We were just looking at systematic reviews. We weren't looking at a lot of the individual examples. We weren't looking at a lot of the grey literature because we just didn't have time to do so. But we were picking up the important lessons and then sharing them. And then we're publishing what we found to share with others around the world, which I think is really important as well. So wherever possible with the work you're doing, make sure you've got those strong partnerships with government, whether it's at the local health district level, the state level, the national level, or globally with the WHO, the OECD, whichever partners you're working with. And again, I'm preaching to the converted because the Kirby does this so brilliantly with our national strategies for BBVs and STIs, which work very closely with the Australian government and with the states and territories through the Bloodborne Virus Steering Committee of the AHPPC. But every piece of research you do, we need to be thinking about how do you get your findings out there. One of the lessons I learned early in my career was that when you publish something, you need to have an advocacy strategy for how you're going to get your messages out. Just publishing in a journal and then walking away from it is not the way you influence change in clinical practice or change in government policy. Having an advocacy strategy to talk to the media, generate some public discourse, share your findings with the relevant people in New South Wales Health, the Australian Government, Department of Health, or wherever it is a really important component of the research that we're doing. But often it gets left off as people move on to what's next. And just looking around this room, there are people who do this brilliantly, who you can learn from, who become trusted advisors, trusted friends by governments, the sort of people who get rung up by Kerry Chant to say, here's the worry that I've got. Can you please give me some advice? And Kerry's very good at that. She reaches out and talks to a number of people, informing opinions on what she needs to be doing very rapidly, but also that we're critical friends of the governments in respectful ways. But, if there's something happening that we're worrying about, we don't think it matches with the evidence, that we're able to make contact and say, we're concerned about this, we're concerned about that. Getting involved in committees. One of the I've now been on Australian Government Department of Health committees non-stop for the past 30 years, since Brian Howe was the health minister. Most of you won't remember who Brian Howe was, but he was the Labor Health Minister under Bob Hawke, and he introduced the divisions of general practice, which now are our primary health networks. And as a junior researcher and member of my college, I was asked to join one of the committees, which helped to set some of that up a long, long time ago. Being known makes a real difference, and being able to then work with your colleagues. And then, if an opportunity like this comes your way, you're ready. And you can apply what you do. I was really grateful to have had the experience as an HIV clinician over many years, to have chaired the McBeavis over many years with the support of many of you here. Michael Kirby, your patron and namesake, rang me up when I came back to Australia. My position was announced and said, oh, Michael, I don't want to sound like Winston Churchill, but all your paths in your career have been leading to this point. And he was kind of right. It was a role where I was able to use lots of the things I'd learned in the past. And, I hope that you get those opportunities too. So, Mr. Chair, I'm going to stop there, but happy to take any questions which people may have.
Thanks very much, Michael, for wonderful insights from really being in the engine room of the response to the Australian pandemic. We'll have questions, but I just wanted to start by just building a little bit on your latter sort of reflections there in terms of the role of expert advice in informing government policy. And do you feel that it was strengthened through COVID? Do you have some optimism for the future in terms of that relationship between expert advice and government policy?
Yeah, so the answer is yes. I think it really was strengthened. And government, especially in the first 2 years of the pandemic, we had the Prime Minister, the Minister of Health, all the premiers and chief ministers saying we are making decisions based on the public health advice. Sometimes they did, sometimes they didn't, but that was what they were saying. And they were reaching out and hearing what people were doing. It was a challenge for government, especially because the media were, as they do, trying to find people with different points of view, which, as we know, can be confusing for the public if you're getting different views on what to do and how to protect yourself. One of the very clever things that Brendan Murphy got me to do quite early on is that we held a forum every 3 weeks for all the identified media experts. So public health, epidemiology, clinical care, and others, inviting them to come to a webinar where Brendan, as the Secretary of the Department, Paul Kelly as the Chief Medical Officer, John Skerritt, the head of the TGA, doing all the approvals for vaccines and treatments, the Chair of ATAGI, the Technical Advisory Group on Immunisation, and Sharon Lewin would say, here's what's happening, and then field questions. And the reason for doing that was to make sure that when people did have a microphone put under their mouth to speak, that they actually knew what was happening around the country. And yes, they could provide different pieces of advice, but it was based on what was actually occurring rather than people operating in a vacuum and not knowing what was happening. And I think that was really helpful as part of the national response. It was certainly fascinating. We learned a huge amount, and the experts brought to the government a whole lot of what was happening through their networks around the world as well. So it was very enriching for all of us.
Michael, thank you very much for that inspiring presentation. And I think on behalf of everyone in Australia, thank you for everything that you did during COVID. Yes, it was amazing. Just, I guess, what you mentioned in your presentation about vulnerable populations and particularly rapid testing, which existed molecular testing in the remote First Nations communities. Probably, as you know, we were asked by the First Nations COVID advisory group to help support the primary care services to enable them to offer those molecular tests so that they could fast track their responses. And that was under their guidance, but also in partnership, particularly with Lucas Totoka, and just to thank him as well for everything he did during the pandemic. Getting to my question, I guess at the end of your talk, you mentioned the future and the system. So that particular program has existed now for 3 years with funding from the COVID-19 response. And of course, all that funding is getting smaller and smaller and smaller. So I wondered if you could comment about the future of infrastructure programs like that, and how do you capitalize on the lessons versus the funding needed to maintain the infrastructure going forward? Because there was such incredible work put into programs like that and many other systems that exist in Australia. But I think we're at that critical point of the COVID funding becoming smaller and drying up, but that real strong need to maintain systems.
It's really, really important. And Rebecca, thank you for the work that you and the team here led on that point of care testing into remote communities, which was wonderful to see. And as I say, it totally shattered the opposition to point of care testing that we'd had from the pathology industry for a long time. And we need to make sure that it's sustainable. And I think that's part of the secret. With reforms, we're not going to get continuing special money for things. Things need to become part of the regular healthcare system and the way that things happen. And rather than relying on research grants or relying on government funding, the government is pulling back on a lot of the investments that it made during COVID-19 for very good reason. We have $1 trillion of intergenerational debt, which was accumulated during the pandemic. Yes, we have had some good news on the budgetary cycles over the last year or so, but there is a lot of that we're going to be paying going into the future, and governments make hard decisions about what continues and what doesn't. So I think the important thing is to try and make sure that this becomes enshrined. It's a role for Nacho, it's a role for the Royal Flying Doctor Service, it's a role for all of primary care, actually, because being able to do those point of care tests, whether it's for COVID-19 or whatever, when you have the patient in front of you, is much more powerful than sending them away, getting a test. Maybe they come back, maybe they don't. And when you've got it there and you can actually do something right here and now, is a real opportunity to affect real change. So the people who are behind this, you need to make sure that your voice is strong. and that you're continuing to advocate and using your partners to do so. And Nutfield, of course, is a very strong partner there.
There's an online question, Michael. It says, thank you, Professor Kidd. What was the prevailing view among peers in the department? Oh, I just lost it. On fresh air, ventilation and air filtration, particularly in aged care and the community, in light of discussions from academia and healthcare organisations at the time?
Yeah, so I know Raina's here and is an expert globally in the field. Right from the outset, it was clear that we had an airborne problem with COVID-19. And we saw this with initial examples of the choirs and the orchestras and the restaurants and so forth, with transmission all around the world. We then got a whole lot of, I think it's fair to say, internal arguments about, well, what do we do? What are the recommendations? We had a lot of advocacy happening, a lot of really important research, which was carried out particularly in hospital settings, looking at airflow, and the Royal Melbourne did some amazing work there in areas where we saw outbreaks occurring. I think part of the challenge related to the existing infrastructure. You can't change the existing infrastructure overnight. Yes, you may be able to open windows, but there are times on this continent that we live on where you can't have open windows in nursing homes and in hospitals and so forth to allow ventilation. We had the competing challenge of not enough adequate PPE being available, particularly very early on. So that was added to the stresses. I think that there's been a lot of good work happening, and this is part of why we need to make sure that the lessons don't get dropped, and we need to do like they did in Toronto. And when we're building our next hospitals and nursing homes and primary care clinics and whatever else, schools, we need to make sure that the lessons from COVID-19 are being applied in there.
Michael, it's Trish Greenhouse here from the UK. That was terrific, just really, really exciting. I totally agree that we have a responsibility to learn lessons and capture those lessons in a way that will inform the next pandemic. I've just come from UK, where we're in the middle of an inquiry, a public inquiry into what went so catastrophically wrong in the UK. We've got the person who was the Secretary of State for Health saying he won't give evidence to that inquiry unless he is guaranteed immunity from prosecution. We've got questions being asked. Why were the people fast-tracked to advise the UK government? Why were they people who'd never published anything on COVID-19 and who didn't believe in airborne transmission? Why were those people handpicked to advise the government? You've alluded to dreadful things happening in care homes and hospitals. So my comment is not a question. The lessons that need to be learned, I think, have to be international comparative lessons. There's some fantastic things that you've described in Australia. I'm sure there's also some slightly more embarrassing lessons that will be turned over. I'm sure you will do that. But I think one of the really, really important things is to say, hang on a minute, why did this go right in Australia? Why didn't it go right in Italy? Why did it go wrong in UK, etc.? And that international comparative case study work is something that we should all be collaborating on internationally. Yeah, and I'd love to do some of it with you.
Yeah, no, I totally agree. And there are lots of lessons for Australia from other parts of the world. There are countries which did so much better than we did in a number of different elements of the COVID-19 response. I think we did well. I think we led the world when it came to having a strong focus on primary care embedded into our national response, and I hope that gets highlighted. But in the review that we've got currently taking place, we have a similar challenge with the review that Catherine Bennett and others are about to lead here in Australia. It's not a Royal Commission, it's not a parliamentary inquiry, so anyone who testifies is not covered by privilege, so could be sued if they said something about someone else which was found to be offensive, which makes a number of us feel a little bit anxious about testifying to that particular committee. I mean, I can't wait to talk to them if I'm invited, but I know others are concerned. But I think you're right. And my worry, last week I was in Washington, DC. I was at a meeting hosted by the Inter-American Development Bank, one of the World Bank agencies, for health ministers and finance ministers from the countries of the Americas, North America, Central America, South America, the Caribbean. And most of them have forgotten about COVID. They're there wanting to get money for their new hospitals. And I'm saying, well, you need to be investing in strengthening primary care in your countries. The countries which did really well were those which had strong primary care, not just really good hospitals. And they're going, yeah, but the Development Bank doesn't fund primary care. They only fund hospitals. So that's why we're here. We're here to get money for our hospitals. I'm going, well, when you do fund your hospitals, are you going to learn the lessons in the design of those hospitals? Well, we've got great American architects who are going to work with us on our hospitals. I'm going, not sure I'll be looking to America for all the solutions about building a pandemic-proof future hospital. Maybe look somewhere else, but it's the challenge that we've got.
Thanks so much, Michael. Look, I'd really like to thank you for a wonderful seminar, but also for amazing commitment and leadership through the pandemic. Thanks very much.